Welcome and thanks for joining us for today's ASA webinar, Mental and Emotional Health in Later Years, which is part of the Empowering Professionals and Aging series presented by Homestead, Inc. We will be getting started shortly. The slides for today's presentation are available under the tab on your screen labeled Resources. And under the tab labeled CE Application here, you will find information on how to obtain CE credit for this event. You will have 60 days to complete a continuing education application, and it may take up to 30 days from the date of your application in order for us to process and issue your CE credit. If you are not logged in directly to this webinar, that is, if you are watching as part of a group and did not log in using an individual confirmation URL, you will not be eligible for continuing education credit because we have no way to track your online attendance. If you'd like to receive continuing education credit, please be sure you log in using a confirmation URL you received after individually registering. If you have questions during the presentation, you can send those anytime using the questions box, and we will save those for the last 10 to 15 minutes of today's program. And now we would like to welcome today's presenters. Dr. Doreen Marshall is Vice President, Mission Engagement at the American Foundation for Suicide Prevention. As a psychologist with experience that spans clinical, educational, and professional settings, Dr. Marshall has been engaged in local and national suicide prevention work for nearly 20 years. Dr. Lakelyn Hogan is a gerontologist and caregiver advocate at Homestead. She educates professionals in aging, families, and communities on the unique challenges that older adults face and the resources available to help them thrive. Hogan has worked in the private and public sectors of senior care services and has spoken at national and international conferences on caregiving and aging, plus serves as a resource to the media. She is a board member of the National Alliance for Caregiving, board chair for the Dreamweaver Foundation, and vice chair of the Alzheimer's Association Dementia Care Provider Roundtable. Now I will turn it over to Dr. Lakelyn Hogan.
Thank you so much, Jen. Hello, everyone. I want to thank you for taking time out of your day to join us for this very important topic of mental and emotional health in later years. I'm honored to have Dr. Doreen Marshall with us today. She'll be sharing in just a bit, and we'll be talking about how our mental and emotional health is impacted in our later years. But if we stop for a moment and reflect back on this past year living through a pandemic, it really has impacted all of us in a variety of ways. Many people have experienced heightened emotions, and some have experienced mental health symptoms, some of which for the very first time. And while mental health has been a very hot topic during this pandemic, for many people, it's still a taboo topic. We find this especially true among the older generations. And this can be problematic because we know that untreated mental health disorders can have a significant impact on older adults, such as social isolation, placement in long-term care facilities, and suicidal thoughts. Older adults are less likely than younger adults to receive mental health or counseling services. And when they do, they're less likely to receive the care from a mental health specialist. So we'll be talking more about all of this in today's presentation. But I'm so glad that all of you have joined us because professionals in the aging space play a vital role in helping your older clients, the older adults you work with, and their families and loved ones recognize the signs of mental, emotional distress and support them, whether it's helping them obtain service or being that constant sense of support for them as they live with a mental health issue or work through mental and emotional issues. So before we dive too much deeper, I thought I would quickly share our objectives here on this slide. So we're going to start by talking about the prevalence of mental and emotional health issues among older adults. We're going to talk through some of the types of mental health issues that are common in later years. We'll also do a little more reflecting on the pandemic's impact on our mental and emotional health. We'll learn warning signs of mental distress and suicide, and then I love to leave everyone with some tools and resources to support individuals and family caregivers. So we'll start by talking a little bit about mental health across the lifespan. First, I want to make sure that we're all on the same page that mental health issues are not a normal part of aging. If you look at the older adult population, approximately 26% of adults age 60 and older meet the criteria for a diagnosed mental health disorder. The age of onset really does vary by disorder, and 90% of those with a lifetime case of a mental health disorder, that disorder usually starts by about mid-40s. The rate of mental health disorders really vary by setting. We do see a higher rate in nursing homes, especially if you kind of look back at the history of mental health. There was a deinstitutionalization of mental health services, pushing services more so into the home. And as a result of that, we do see at times higher rates of those living with mental health disorders in nursing home settings. And when we consider mental health across the lifespan, we see generally three patterns. Those who had a mental health disorder early in life and maintained that into later life. Those who grew older and experienced a mental health disorder for the first time later in life. And then those that came to life with what is referred to as a liability that was exacerbated by the conditions of later life, producing a mental disorder. So a liability could have been a genetic influence, a life stress, perhaps a trauma in younger years that manifests later in life. And again, mental health issues are not a normal part of aging, but they are, some of them are mental health illnesses and disorders are common among the aging population. And sometimes families tend to think, especially with depression, oh, that's a common occurrence in older adults. So it's not something that we should probably address with mom or dad's doctor. And that is a myth we definitely want to debunk. And we'll talk more about that. But there are several factors that contribute to mental disorders and mental illness. They call this the Biopsychosocial Model of mental health disorders, and it really points to a combination of three factors: our biological, psychological, and social factors. So the biological factors, these are things like our genetics, a medical disorder, medication, other psychoactive substances, nutrition, hormones, a physical trauma. Those are those biological factors. The psychological factors, these are learned behaviors, faulty or unhelpful ways of thinking, the way a person copes, their coping strategies, a person's defense mechanisms, their self-esteem, and even their personality traits. And then we have social factors. These are things like culture, race, socioeconomic status, relation and influence in one's environment. And really these three factors are interrelated elements. So it's important to understand that they're interconnected. So when we work with older adults, we need to look at these various factors, especially when assessing and treating mental health disorders. And I wanted to share an example of how these three factors can be interrelated. So I thought I'd share with you the story of Jean. Jean struggles to make herself do her daily routine. She has arthritis, which makes her activities of daily living more challenging. It's hard for her to admit that she could use help, and she can't imagine having any sort of professional help in the home. She is also longing to feel safe in the neighborhood that she lives in, as it is starting to deteriorate. She's lived there for years, but crime is becoming more common. She's frequently afraid that she could be in danger, and she imagines all sorts of scenarios: break-ins, robberies, vandalism. And when she has these thoughts, she feels her heart start to speed up. She feels faint. Her face and neck become uncomfortably red and hot and clammy. And she recently stopped going out and about for fear of having a panic attack in public, and also to keep herself safe from her perspective. She's asked her adult children to bring groceries and supplies to her house because she rarely leaves the home anymore. And in this scenario, it seems that Jean is suffering or living with an anxiety disorder due to these various factors in this biopsychosocial model. So the biological factors that one of them that she's dealing with is her arthritis. It's making her daily life a little more challenging. For psychological factors, she's having these thoughts that she's unsafe, these thoughts that aren't necessarily helpful to her in her situation. And then social factors, the safety of her physical environment. So again, when we're working with individuals and we're educating family caregivers, it's important to understand this model, these factors that can all work together and can impact an individual's emotional and mental health. So I thought that it would be helpful to talk through some of the more common mental health disorders, symptoms that we see in the aging population. And I know for me in my career, I've worked mainly with older adults who are experiencing depression or anxiety. And while depression seems to be somewhat common among the older population, it's not a normal part of aging. I'll probably say that 3 more times throughout this presentation, just because I don't want people to think that it is normal. We know that as we age, it is normal to lose loved ones, to experience grief, and throughout life to really have normal ups and downs, times when we feel sad, or we are grieving the loss of a loved one or the loss of independence. But those that experience depressive symptoms to the point that it is debilitating or impacts their daily life, that's when it's really important to make sure that the individual meets with a healthcare provider. Because we know that depression can be treatable. So an individual can meet with their healthcare provider, talk through the symptoms. They can try cognitive behavioral therapy, talk with a counselor, and medication is also an option for some. And it's especially important to bring up symptoms of depression, because sometimes symptoms of depression can be confused with other medical problems or with cognitive impairment. So when we think of those symptoms of depression, often we think of the cognitive and somatic symptoms. So cognitive symptoms such as complaints about memory, executive function deficits, difficulties concentrating. A lot of times I hear older adults talk about it and they just feel foggy. They have kind of a brain fog. And then the somatic symptoms, it can manifest in things like a fatigue, lack of energy, sleep disruptions, not being able to fall asleep, waking up a lot during the night. And other symptoms can be a loss of interest in activities and even a loss of interest in living in general. And it's believed that the prevalence of depression is actually higher in older adults than is actually diagnosed. And again, that goes back to what's believed to be that stigma around mental health among the older population, and also the belief that, depression is just a normal part of aging. It's just a part of getting older. So often, again, families, older adults, they don't bring these concerns to their healthcare provider. They're not diagnosed and they're not treated. But there are, again, treatments for depression, medication, psychotherapy. Oftentimes those who have struggled with lifelong depression or have lived with depression most of their life, they might have a more complex treatment compared to somebody who's experienced depression for the first time in later life. But again, it's really important that we address concerns about possible depression or depressive symptoms. Another common mental health concern that I see in older adults that I work with is anxiety disorder. We see that this is less common in older adults than it is in younger adults. The prevalence in the older population is reported anywhere in the range from 3 to 14%. Again, it's hard to kind of get a hard number on how many older adults are living with anxiety. But we do know that the hallmark symptoms are the cognitive, affective, and somatic symptoms. The cognitive symptoms would be that ruminative thinking, that distractibility. The affective symptoms is worry, fearfulness, low mood, irritability. And then the somatic symptoms, the racing heart, sweating, some upset stomach, and signs of just heightened physical arousal. And if we think back to that story of Jean, when she started to have those kind of worrying thoughts about her safety and her environment, she started to have those somatic symptoms. Her heart would race, her palms would get sweaty. I personally have struggled with anxiety for about the past 10 years, so I can identify with a lot of these symptoms. And we know that there are different types of anxiety. I won't go too deep into this, but there's generalized anxiety disorder, there's panic disorder. Some individuals have a specific phobia or fear. Some people have social anxiety disorder. And then some people have agoraphobia, which is a fear of leaving the home. So you might see those types of anxiety disorders in those that you work with. Then we know that there are also some additional mental health disorders that you might come across in the individuals that you work with. We see sleep disorders in the older population. I know my grandmother always talks about how she does not sleep like she once did, and it's very frustrating to her. It really is, sleep difficulties really are more common in older adults than any other group, occurring in about half of older adults at any given time. And the consequences of sleep disorders is really significant. There's a greater risk of physical and mental health comorbidities, higher rates of health service utilization, greater functional disability, a reduced quality of life, and some studies have even shown ties to more mortality. And sleep disorders can include a variety of types of disturbed sleep, but again, it is pretty common in older adults. We also know that cognitive impairment and neurological disorders happen frequently when we look at the older adult population, and this really encompasses a wide range of disorders that impact or that involve some degree of deterioration in cognitive functioning that affects daily life. Again, that's not a normal part of aging, but it does prevent certain challenges for the individual in terms of functioning. So there's usually a certain area of the brain affected depending on the type of cognitive impairment or neurological disorder. Often the severity and the rapid or the progression of the disease differs, again, depending on the type of disease. So some Alzheimer's disease would fit into this category, Parkinson's disease, frontal temporal dementia, Lewy body dementia, those would all fall into that bucket of cognitive impairment and neurological disorders. And then another category that I haven't seen as often, but can occur is obsessive compulsive and related disorders. I guess one of the more common in this category would be hoarding. I'm sure many of you listening in on this call have walked into the home of an older adult and really have been overwhelmed by the amount of possessions that the individual has. And for many, that can cause safety issues. I could do an entire presentation just on hoarding disorder alone, but it can be something that happens, especially as an individual gets older. Those who have hoarding symptoms or who experience that, oftentimes the behavior of hoarding becomes more kind of compounded as they get older. We also know bipolar disorder, substance-related disorders are also types of mental and emotional health disorders. And then another one is chronic pain that you might see in the individuals that you work with. So those that experience chronic pain, it can kind of manifest in both biological and physical. It can really, I don't know if you've experienced chronic pain, but it really not only is physically manifesting, but oftentimes there is a mental and emotional component that goes along with it. Also, post-traumatic stress disorder occurs for some individuals, especially in the veteran population. If you work with a lot of individuals who were veterans, who are veterans, they might experience that type of mental health disorder. And then a few others are sexual disorders and personality disorders. So while it's important to be aware of the different types of mental health disorders. There are also some important considerations for the older adult population that we also just need to be aware of. I need to educate those family caregivers that we work with to just kind of be on alert for. One challenge in diagnosing a mental health disorder among older adults is really distinguishing between and among age-related cognitive changes. So, as I mentioned earlier, sometimes cognitive disorders can be confused for depression, or sometimes they have similar symptoms. So it's really important that an older adult is evaluated by a medical professional so that the proper diagnosis is determined, because mild cognitive impairment, Alzheimer's disease, and other major neurological disorders can again have some of the same symptoms. So oftentimes an interdisciplinary team collaboration is needed to help make sure that the proper diagnosis is given. I know that, again, especially for depression and dementia, sometimes there is an overlap in symptoms, and there is research that I've actually been reading up on quite a bit lately. Those who have depression could be at an increased risk of dementia, and then the reverse is true. Those who have depression could be at an increased risk of dementia. I hope I didn't say that twice, but it is. There is a risk on kind of both sides of the coin. So again, it's really important for an older adult to have that medical evaluation. And if an individual is diagnosed with dementia, it's important for family members to be aware of the signs of depression so that an individual can get treatment if they are experiencing depression. And then for someone who has depression, it's important for family members to also be aware of the symptoms of dementia so that family members know when it is appropriate to seek out medical help and attention for their loved one. Another important consideration is comorbidities, or having multiple chronic conditions, and that is really common with the aging population. It might be that they have multiple mental health disorders. It might be that they have a physical illness along with a mental health disorder. And so this can really complicate a treatment plan. Oftentimes for older adults in general, they have multiple physicians, healthcare providers, clinicians that they see on a regular basis. So it's important that families or loved ones of the older adult is making sure that those physicians and medical team are communicating with one another. If multiple providers are prescribing medications for the various illnesses or diseases, that there's a med reconciliation happening, because again, that's where it's easy to overlook. If one doctor is prescribing something for depression, another doctor is prescribing something for arthritis, making sure that both doctors are aware of the entire picture of health for the older adult. Something else to consider are also the common stressors that come with aging that could contribute to a person's mental and emotional health or distress in those areas. It could be money issues, loss of independence, conflict among family members, a decline in their own health and well-being. So it's really important to be aware of those life changes that could impact an older adult's mental health, and encouraging them to talk about it and to seek professional counseling if needed. And then we also know that it's important to not shy away from the discussion around mental health, around suicide with older adults. When we look at mental health across the lifespan, we see that suicide rates among older adults are sometimes seen at a little higher rate than the general population. So oftentimes suicide is challenging to talk about. That's why I'm so grateful to Doreen for joining me today to talk more about that, because often we don't see this topic discussed when we talk about aging, but it is something that needs to be a consideration for all. So I'm going to now pass the torch over to Doreen to talk more about how COVID has impacted our mental health and to talk more about the warning signs of suicide. So Doreen?
Thanks, Lakeland. Everything that you said is so important when we think about mental health and suicide risk in older adults. And so, to kind of put a picture on this, particularly right now during this period of COVID, one of the things to remember, like you said previously, is that older adults are at a higher risk for suicide compared to other age groups. And so the thing we should remember during this time of COVID is that not everyone is having the same experience. We're all experiencing the pandemic, but what our individual experiences look like varies quite a bit. So, when we look at kind of just the last few years, we have seen an increase in anxiety and depression rates among adults 65 and over. Particularly women reporting higher rates than men. But that also, this is kind of a balance of also thinking about the life experience and the perspective that being an older adult brings. So, I've said to folks, particularly during the pandemic, I have small children, and one of the challenges of being a child right now during COVID-19 is that you don't have the life experience to know that this is a year, this is a season that will pass in your life, that things will resume and look much more like your day-to-day functioning before. When you're an older adult, your resiliency does come from some of that having more experience and perspective. And, certainly during this time of COVID, that is something that we have seen. I would say, though, that when we think of the big picture of mental health and know that while we all have mental health, there are things that we can do, things that we experience that impact our day-to-day mental health and really can shape that trajectory for us. And like Lakeland pointed out earlier, the presence of a mental health condition already, makes kind of can impact your mental health going forward. So while we know in individuals any period of chronic stress has the ability to kind of change your biochemistry when it comes to mental health and disorders like depression or anxiety, what we do know is that if you already have those vulnerabilities, that living through a stressful period can also exacerbate an existing mental health condition, can make it worse certainly, but it can precipitate one for individuals that have some vulnerabilities. Certainly the presence of pain, increasing debility, and I think one of the things we've seen with COVID is that certainly in populations that have a higher rate of disability, that their kind of perspective about COVID may be that they've felt more vulnerable, they may have had more challenge accessing caregivers, or if they are dependent on caregivers, kind of this idea of having more people or being exposed to more risk because of their dependence on caregivers. Certainly the social isolation and disconnectedness from others has been pronounced for across many age groups. But I think when we think about older adults and maybe their challenges accessing technology or other things that we've used to facilitate social connection during this COVID time, we should be mindful that those differences may make someone feel even more isolated or disconnected. This is a period of loss. The death toll from COVID and the idea that older adults were dying at a higher rate than other age groups really does underscore that older adults are much more likely to have experienced losses within their families, losses of peers during this time. And then certainly the disruption in day-to-day routines, things being closed, not being able to go to a grocery store or do things in your usual way. Those routines that most of us rely on in terms of our mental health certainly has been disrupted during this time. So So, it kind of the question I'm asked a lot in my work at AFSP is, how do we support one another during COVID? And certainly there are things we can do right now. We are still in this COVID period that will can improve someone's mental health trajectory and certainly bend their trajectory away from suicide risk. And one of those things is about staying connected. So whether it's making it a point to regularly check in or use video chats or calls. I was sharing with Lakeland that my mother is an older adult, and during this period of COVID, I had found a way to get her an iPad so we could video chat, knowing that I would not be able to visit as frequently. Those things we can do to help people stay connected, be connected, and feel like someone is connecting with them through checking in are really important. Helping them with medical advice, certainly while there's been an increase in telehealth appointments, we should be mindful that technology may not be comfortable to everyone, and certainly helping to facilitate that. And when possible, keeping folks connected to the activities that they know and love. Many activities have been moved to different formats, and really finding new ways to keep people connected. Offering to bring by a meal, run an errand, or just really doing anything that would help lighten their load can really remove some of the stress. And, connecting to them, I think one of the things that this period has also kind of engaged all of us around is meaning and purpose. And so finding ways to engage older adults where they feel like they are making a contribution, whether it's by sharing experiences, sharing lessons, giving advice, those kinds of things can really help solidify a person's sense of meaning and purpose. And then, of course, just appreciation and gratitude, which helps us all, but particularly during times of stress. At my work at the American Foundation for Suicide Prevention, I spent a lot of time talking about kind of how do you know when someone's risk for suicide may be increasing. And what we know about suicide is that the vast majority of people who die by suicide struggled with a mental health concern, either diagnosed or not, in the time leading up to their death. And there are a few data points that I think are important to be mindful of. For those that die by suicide, a large majority of them saw a primary care provider in the time leading up to their death. So this is kind of, for me, one of the things that I share a lot is the more we can equip those gatekeepers in the community, whether it's caregivers, primary care doctors, or others who have regular contact with older adults, to know what the warning signs are, to ask about mental health, and to not be afraid to ask specifically about suicide risk. These things can really help in terms of early detection and treatment of mental health concerns. So like Lakeland said earlier, thoughts of suicide are not a usual part of aging and can be a sign of worsening mental health. While we know many people live with thoughts of suicide and never attempt suicide, I'd like to think of thoughts of suicide as kind of our body and mind's kind of warning light or check engine light. It's kind of an indicator that things are worsening, mental health may be deteriorating, stress may be increasing. And so we really want to pay attention when someone indicates they're having thoughts of suicide. And these can be indicated in three different ways. The person may say something, so they may mention suicide. They may mention it in a more veiled way, saying they feel like they have no purpose or life is not worth living. They may speak about that they should kill oneself or that suicide seems like a good option. Or they may just express extreme hopelessness and despair, having no sense of the future, having nothing to look forward to. Often these are indicators that the person is feeling very hopeless, and hopelessness and desperation are two of the mood states that we really connect to suicide risk. So when someone is talking in a way where they're either mentioning suicide specifically or conveying this extreme hopelessness, we should pay attention and certainly follow up and ask about that. Behavior, you may see changes in substance use. You may see them engage in what we think of as reckless behaviors. This can also be not taking medication. It can be doing things where they really don't care what the outcome on their health will be. While changes in sleep and eating may be usual for the person, we want to look at anything that's becoming more acute or more dramatic change. So, for example, someone who says they're not sleeping or that they're awake most of the night. We know that not getting good sleep can impair judgment. And when it comes to suicide risk, this is something we pay a lot of attention to. Certainly, isolation, particularly isolation where they are withdrawing from others. They are deciding not to stay connected or deliberately not connecting with those they would normally connect with. And certainly giving away possessions can be an indicator in terms of behavior that the person is thinking of suicide. And then finally, mood states. And the big mood states, like I mentioned previously, hopelessness, desperation, increased sadness, agitation, the sense of kind of anxious restlessness can be an indicator of suicide thoughts. And certainly expressions of rage or anger can be connected to thoughts of suicide. So what do you do if you are aware or you become aware that someone is showing warning signs of suicide? Well, the first thing we need to all do is be aware. And once you learn what these warning signs are, we look for a picture. I think about risk coming together in a bit of a constellation, which gives us an overall picture of what's happening with someone. But we certainly want to be vigilant and pay attention. If we're noticing this, we want to reach out, and we should not be afraid to ask directly about suicide. What we know is most people are afraid to ask directly, but what we know is by asking directly, the effect on the individual is actually that it's often met with relief, meaning that they feel like someone is noticing their distress, noticing their pain, and reaching out and connecting. So, I'm often asked, how do you reach out and how do you ask? And what I say is I often comment on what I'm noticing. So I might say something like, you've said some things that make me think you're feeling really hopeless lately. And sometimes when people are feeling that way, they may have thoughts of suicide or wanting to end their life. Are you having those kinds of thoughts? Asking directly is a way of reaching out. And then I always say, and to pair that with an expression of care or concern, telling the person, you mean a lot to me, I care about you, I want to help, I'm concerned and I want to help you get through this and get what you need. I think there are people that can help, and reassuring them that you're there to support them. Then you want to seek help, and we'll share some resources, but certainly the National Suicide Prevention Lifeline number, reaching out to a primary care doctor with them. There's a number of ways you can connect to help, a mental health provider, lots of different ways. And then, the last piece of this, and I mentioned this specifically around firearms because we know firearms are a highly lethal method of suicide. For older adults that may have firearms in their home or access to them, we want you to go an extra step and make sure they're secured and that the person who's at risk for suicide does not have easy access. This can be using a cable lock on a firearm, having it in a safe. It can be disassembling a firearm or so that access is not easy. It can be making sure a key to a lock is not on the person of the individual who is at risk. So taking those extra steps. And then I think there's a general perspective about trying to keep the home safe. So if you believe someone's at risk for suicide, not only looking at firearms, but looking at medication excess, particularly expired medications, those sorts of things that may not need to be kept in the home or can be discarded. You may work with an older adult to have a pill box and to store excess medication with a relative or with a caregiver. These kinds of things, when you know someone's at risk for suicide, taking an extra step to make the environment safe can really be the difference between a death by suicide and saving a life. I've said some of these already, but just to reiterate, you want to ask directly about suicidal thoughts and be prepared to listen. This is not a time where you need to solve the problem, but I think just your presence and listening can be really important. Involve a primary care doctor or mental health professional and not be afraid to help the person coordinate their care, but certainly reaching out to a primary care doctor with concerns about mental health is a good first step. Certainly a mental health professional or getting a referral is another excellent step. Keeping hotline information handy, the 1-800-273-TALK number or the crisis text line number. You can text the word TALK, T-A-L-K, to 741-741 or dial that 1-800 number. Both of these will connect you to a trained person who can, if you're the person in distress, can talk you through and listen. But if you're calling on behalf of someone, can also give you some guidance about resources. You know, we know when it comes to mental health, anchoring in our routines and keeping to routines can be really important. So encouraging regular sleep, eating, and routines as much as possible, and particularly now when our routines have been so disrupted by the pandemic, as much as we can anchor ourselves in a daily schedule, that can be super helpful. We know those with chronic medical conditions, and particularly chronic pain conditions, are at higher risk for suicide. So making sure we address those conditions and treat pain adequately is important. It's also important that we look at medications and make sure that, particularly when mental health symptoms are present, that we are reviewing that in the context of an individual's current conditions and medications. And then also staying connected is so important. Really quickly, I will just mention a few things before I turn it back to Lakeland. You know, like I said earlier, there are things we can do, all of us, to improve our mental and emotional health. Certainly being mindful when we are feeling more anxious and doing things to help center us and connect us to calm. So, you know, I often say anxiety tends to spiral, but we can also do things to help spread calm. And so whether that's through connection, whether that's through having a way to kind of release our anxiety or share our concerns, certainly keeping trusted individuals, but also things like meditation, regular exercise can help us over time have a better sense of calm and centeredness. We want to make sure that we're not on information overload, and particularly news coverage. We want to make sure that we're not exposing ourselves on an ongoing basis to news coverage that's frightening or that repeats stories in a sensationalized way, and certainly finding ways to limit it and take it in when we're ready versus having that constant exposure. Remaining cognitively active, you know, this is where things like puzzles and, you know, the many different games, online games, and things that keep our brains active, but also it helps with cognitive flexibility when we do have distressing thoughts. If our brains are feeling nimble, it makes it easier to move away from troubling thoughts. I already mentioned exercise and meditation. We do want to watch alcohol use. Alcohol is a central nervous system depressant, and people who feel depressed tend to be more depressed over time when they drink. So being mindful of that, particularly that alcohol can really make us feel more depressed if we're using it and overusing it. Certainly in counseling, any cognitive behavioral techniques can really help us manage distressing thoughts. And then staying connected in our community and getting help in the community around mental and emotional health. It's never been more prevalent now, where there are lots of resources at the community level to help us cope. So I'll turn it back to Lakeland now. Lakeland, I think you're going to cover the last few slides here.
Yes, thank you so much, Doreen, for sharing that really important information. I think it's very helpful to know and understand those warning signs and know kind of the next steps for us to take if we we do have a loved one or someone we're working with that we have concerns about. And you had mentioned that, through this pandemic, there have been more mental health resources available, which I think has been wonderful for us as a community and as a nation and as a world. We do know that there are some utilization barriers. That access to mental health services is at the top of this list. I think it is improving, especially because of COVID. Now more telehealth types of therapy sessions, counseling sessions is available. Also telephonic, so just being able to utilize those services over the phone if the older adult doesn't have a piece of virtual technology or technology that enables virtual visits. But we know that older adults are less likely to use a mental health professional or specialist than the younger populations. And sometimes it's due to the lack of access, or sometimes, it roots back to that stigma. We also know another barrier is a shortage of geriatric mental health professionals and providers. It's wonderful that there are, individuals that work with people of all ages, but sometimes older adults have very specific needs, and sometimes it can be helpful to go to more of a specialized mental health provider. And so we know that there is that shortage and a need for more people who really understand the aging population and their unique challenges. We also know that funding sources can at times be a barrier to service, especially for those who maybe need a skilled level of care and are needing mental health services. Oops, I think we accidentally advanced the slide. I'll go back here. And then another is, help-seeking attitude. Some people have the mindset of, I'm not going to therapy because my problems are my problems. I'll work them out on my own. Again, that kind of mindset that sometimes, that stigma. And some, believe that, symptoms of, depression or anxiety are a normal part of aging, and so they do not seek treatment. Some also have a lack of knowledge around maybe psychotherapy as an option or a fear of therapy. They might have a limited view of just what they see on movies or the TV as to, laying down on a couch and the mental health provider sitting there. So they may just kind of have that preconceived notion and think that it's not for them. They might be hesitating to try it. But I know for me personally, I had to go through several therapists to find a good fit for me. So as we work with older adults, it may be that we need to encourage them not to give up after one session if they don't click with the provider. And also to maybe help talk them through what that kind of treatment option is like so that they maybe are more comfortable and open to it. Another barrier can be transportation. I think that's same with all, access to all kinds of healthcare, getting transportation to an appointment, to talk with a mental health provider or even your physician about your symptoms and your concerns can be a challenge. And I was actually surprised in a survey that I saw recently that stigma was towards the bottom of the list when it comes to the older adult population and utilization of mental health services. So I think, again, conversations like this on mental and emotional health, COVID has really brought to light the need for communities to address mental health and emotional health, and for all of us to get a checkup from the neck up, just as we would get, a physical for the rest of our body. We really do need to maintain mental wellness just as we would our physical wellness. And then the National Alliance for Caregiving, they recently did or collaborated together with NAMI on a resource for caregivers of individuals that are living with a mental health condition. And so on the screen here, I've kind of shared some highlights from some of the research that they did that go into this report, which I'll share how you can access that report on the next slide. But they found that for these types of caregivers, care and support often lasts for years and even decades. And we know that to be true for caregiving in general. And I think it's also important, we talk about the aging population and their need for mental and emotional health, but so many family members, loved ones, are providing care and support to an aging loved one, and their mental health is also of utmost importance. So family caregivers, loved ones, they need to take care of their mental health as well. We also know that caregivers often live with the care recipient that they're caring for if they're the individuals living with a mental health condition, and also that the care recipient is likely to be financially dependent on the caregiver. Also, the responsibility of oversight and care coordination often falls to the family caregiver, and that includes medication management. So at times that can be a little overwhelming for a caregiver to manage. So it might be necessary for us as professionals to provide resources and to make recommendations for people that can come alongside the caregiver and support them. Maybe it's outsourcing that medication management to a medication solution, or maybe it's getting some extra support in the home, such as home care, those sorts of things. Because often family caregivers that kind of fall into this category, they may not have family to assist, and it really does fall to that that primary family caregiver. They feel that there's really a lack of a support system. And that caregiver is also the most important advocate for the care recipient. And so all of these things combined can create stress and levels of burden, whether it's mental, emotional, physical. And so we find that mental health caregivers, they might be at a higher risk of stressors and burden. Again, making it important that we also ensure that they are caring for their own mental health and well-being. So before we open it up for questions, I do want to share some resources. That first one is that guidebook, that resource by the National Alliance for Caregiving in NAMI. I have a picture of it right there, Circle of Care. So they did a research report, and then they put together a guidebook for mental health caregivers. So feel free to download that. Of course, Doreen shared the really important work of the American Foundation for Suicide Prevention. I've listed the website there, and I've reiterated those phone numbers and the text line. And then I've listed a few other resources. If you're looking for a geriatric psychiatrist, there's a website where you can do a search, looking for services in your area, and then support for family caregivers. So I'll leave this resource slide up here for the time being as we open it up for questions. But before we do, I just want to thank everyone so much for joining us today to discuss this really important topic, and I want to thank Doreen for co-presenting with me and sharing some very important information. So Jen, I will pass it over to you for our first question.
Sure. Our first one is, do you think the fear of leaving the home will be increasing across older adults due to COVID or have a serious impact?
Ooh, that's a really good question. I'll take a first pass at it, and then Doreen, I'll let you speak to it. I think actually Doreen mentioned earlier that everyone's experience through this pandemic has been so different and individualized. I think some older adults, they will be impacted in a way that might make them fearful of going out into the community, or perhaps they'll continue to wear a mask or gloves when they go out and about. I think it really depends on the individual, on the mental health conditions that they have, or maybe they have lived with for some time. And I think it might also depend on the support that they have. So I wish there was an easy answer to that, but I think it really is individualized. Doreen, do you have anything else to add?
I would agree, and maybe only add that I think one of the things that we're mindful of is that for people who are struggling with a mental health condition, as things do start to open up and there are more opportunities for people to get out, the fact that they may still mentally not be feeling better may actually be more distressing to them. So that is just something in terms of the big picture.
Yeah, that's a good point.
Okay. Our next question is, what type of sexual disorders does the older adults suffer from?
Yeah, I'm happy to share just a little bit more about that. So, it's not, I would say, as common. I know I kind of breezed over it, but there are, you know, uh, when we think about sexuality as we age, there's actually going to be a presentation done by my colleague April Ibarra. I think it's in September through this webinar series on intimacy and aging as we age. And there's a lot of kind of later life considerations. We have the biological, psychological, social, cultural aspects that really all affect our sexual satisfaction, expression, expectations, and as we age, people still have those desires. I'm not an expert on the sexual disorders, I will have to admit, but we do see that some individuals are experiencing that. So I would say if there's any sort of concerns around that, to bring it up to the older adults healthcare provider to speak with the older adult. I know that sometimes if an individual is living with dementia, one of the dementia-related behaviors that sometimes an individual might exhibit could be seen as sexual inappropriateness. That's where I have seen it most commonly. In that case, it's not necessarily a sexual disorder, it's a dementia-related behavior. And so those types of situations often need an individualized, tailored approach, because often there is an underlying reason for those expressions, those sexual expressions. So that might not answer your question, and Doreen, you might have something to add there, but it's not as common of a mental health condition in the aging population as the others that we discussed today. Anxiety and depression would probably be the two that I see most frequently in my work.
I would agree.
Okay. Our next question is, are there times when you do not directly ask the suicide question because they may be on the fence, and when you introduce the question, they focus on this?
No, and actually this is a prevailing myth that those of us that work in prevention are really trying to get people to understand, that asking someone about suicide will not ever make the situation worse. I think that's the fear we have and why we often don't ask directly. But what we know is that people who aren't suicidal don't become suicidal because they're asked. And that for people who are struggling, the ask is really the thing that lets them know someone is tuned into how they're feeling. Now, it is about, to some degree, how you ask. So you want to ask in a way that's caring and that's lending support versus in a way that's angry or accusatory, but certainly asking the question in a way that genuinely conveys care does not increase any risk for suicide.
Okay. Our next question is, Lakeland, did you have some?
Oh, no.
Okay.
Go ahead.
Okay. Our next question is, family often complains that doctors don't speak to each other. What tips do you have for getting doctors to speak to each other so family isn't sole connector/reporter?
That's a good question. And I think it's one that is unfortunately very common. And I think, it goes back to caregivers are the greatest advocate for their loved one. And I think it's important to bring up those concerns to the healthcare provider, letting them know my loved one sees multiple providers, put it back on the provider. Ask, what's the best way for me to help you communicate with are the other providers, or do you have a preferred method of communication? And then also just making sure that you have up-to-date records of your loved one's medications. And also sometimes, I know the question wasn't directly asked about, managing of the medications, but often that's one of the most common reasons that I hear families, frustrated by doctors not communicating is it comes down to the medications. And oftentimes a pharmacist can be a great resource for the family caregiver that caregivers might not think about. So a pharmacist can help to do a med reconciliation. They can also help to reach out to those physicians if there's multiple physicians, providers involved, and can help with that as well. Doreen, any other thoughts on that question?
Yeah, I would just add that particularly when an older adult is placed on a antidepressant or mental health related medication, it's so important that that gets communicated to other providers. Often when there's been changes like a hospitalization or medical procedures, sometimes mental health medications don't always get kind of transferred through. And you certainly want to make sure that those medications are not discontinued abruptly. So I would just add that, this is another example of the importance of being an advocate when you can.
Mm-hmm.
Thank you. Well, we've reached our hour, so that will be our last question. If you would like to claim CEUs for today's webinar, you will be receiving a follow-up email by the end of the business day that will contain a link to the CEU application. That follow-up email will also contain a link to today's slides. Please note you have 60 days to claim CEUs for today's webinar. And please note it will take 30 days from the date of your submission in order for us to process and issue your CEUs. Dr. Lakeland and Dr. Marshall, thank you so much for the presentation, and thanks everyone for joining us today.
Thank you. Bye, everyone.
Thank you.